in the world of self-funding is how do you start to incorporate AI to help you win business within that, right? In keeping those cases, what can you look at in terms of your own data that will help you either select a group that's going to be more profitable, or just something that will allow you to look at groups in a different manner than you perhaps were looking at them. So that I think is going to be a big focus.
Hey, what's up, guys? Spencer Smith here, host of the Self-Funded with Spencer podcast, sponsored by Pareto Health, ClaimDoc, and PlanSight. Enjoy today's episode. I do always ask, though, is there anything that I can't glean from our conversation, a fun fact, a unique thing about you? The cat conversation came up, which is interesting. But like I've had people, everything from scuba diving to skydiving to racing cars. So I don't know if you have a hobby or an area of interest that you like to share.
So two. One is probably normal, and I mean, I do love to travel. You know, that's definitely something. But I am sort of an amateur mixologist. I like to. I like to make cocktail recipes.
So other than somebody that enjoys drinks, so what's an amateur mixologist? I mean, you like kind of learn how to
like how to make things. You know, take something that is pretty standard and put a twist on it, or try to make it my own. And I have a never-ending supply of, thank you very much, never-ending supply of people who are willing to, be taste testers for me. Yeah. So,
So what are we making these days? Like, what are we toying around with?
Well, so I'm a vodka girl in general. I mean, I do, I coconutty rum, spiced rums, I put together a really nice Mai Tai spin, I have to say.
Okay.
So, but I had this drink over the weekend that had strawberry vodka, which I never had before. And I'm like, I don't know if I'm going to like that. But I was like, I really like this. So now I'm sort of like, I want to get myself some strawberry vodka. And I was like, I think I can put it together with some Saint Germain, which is elderflower liqueur. I'll add some cranberry, maybe drop in a little lime, and
so mixology is not just learning how to make existing drinks, but it really is experimentation and pulling flavors.
For me,
for you,
okay, right? Okay. Because I have like a laundry list of recipes that I keep on my phone of things that I've gone over the years that I'm like, I like this drink in a restaurant, and put it together, or I see something in a magazine and we'll try that. But for me, the most interesting thing is trying to put a spin on it. Or drinks are so similar. Somebody calls it one thing, somebody calls it another, and it's just a different ingredient here or there. So I like to do mashups.
Okay. So I'm trying to think. I'm not a big cocktails person, although I'm a kind of boring gin and soda guy, Hendrix and soda. But I've gotten into a spicy margarita, which I don't know why I like the spice element of that. Ranch waters, which I don't know if you're familiar with the ranch water.
I don't know what that is.
A ranch water, I believe, is, oh God, I'm going to butcher it now, so I'm not even going to say. But they're kind of like a flavored drink, more of a day drink, if you will. They make them in a can now, the hard seltzers.
I was going to say like a hard seltzer.
Yeah, you could do the hard seltzer, but a true ranch water, I think, is made. It's a cocktail. Good old fashioned, especially a smoked old fashioned. Do you ever do any of those?
Dark liquor is not for me.
Okay.
Not for me. As a matter of fact, we tried one year. We were going to do for Thanksgiving. We got this brilliant idea in our head that what we do would be a blind taste test of scotches. Oh. And we don't drink scotches at all.
Like true blindfolded blind taste, or just
they're not blindfolded. I mean, they're in bags. But really, get a bunch, from terrible to a really good one and a couple in between. And we do this with a lot of different liquors at Thanksgiving. A lot of times, champagnes and stuff like that. We're very into champagne, and just see if you can figure out which one do you like the best and which one do you think is most and least expensive. But we didn't know Scotch at all. So we were at a restaurant, and one of our favorite waitresses was like, "You guys don't want to do that." She's like, "You're not going to like." So she actually brought us out little nips from the bar of different scotches, and I was like, no, absolutely not. We can never do that. Yeah. So
I mean, I have to be in the right mood. My wife, she enjoys wine. She's a red wine gal. And then if I feel like having a drink at home, it might be something like not even an old fashioned, but just a nice bourbon on the rocks. But I try to control. I want to make sure that it's under obviously control, and I don't know. There's just something about two
during the week, I just wake up better and more refreshed if I don't.
Oh, yeah.
Yeah.
No,
I know it's a weekend thing, right? But
for sure.
I haven't gotten too deep in the weeds, and with little kiddos, God, I couldn't even imagine finding the time.
Yeah.
But so we'll introduce you also as an amateur mixologist if you
Feel
want
free.
to. Yeah. Okay. All right, Daniel, we're rocking. All right, so we got about an hour. We're good to go. Okay. All right, everybody, we're here. I don't even know what episode this is going to be, but I'm number-wise, but it's going to be a great one. I'm here with Stacy Borans, who's not the CEO. I was mistaken earlier. Who's a co-founder and chief medical officer at AMS. How are you? Nice to see you and sit down with you.
Great. I'm great. Great. Thanks for having me. This is fantastic.
My pleasure. Well, so AMS is Advanced Medical Strategies,
yes.
Correct? So before we dive into your background, I'd love if you could just sort of position what today's episode will be about. What is AMS, broadly speaking?
Sure. Broadly speaking, particularly in the self-funded stop-loss industry, AMS currently is really a company that has a software-based platform that is designed for really payers across the whole spectrum. Reinsurers, stop-loss carriers, MGUs, CPAs, brokers, case managers, everybody. And it's really designed to help modernize and insource what we really call the three pillars of our software, which are payment accuracy, risk assessment, and business intelligence.
Okay.
And that through a variety of our products, that is really where we try to focus.
Well, and we're going to definitely unpack those, and that'll be the crux of today's conversation. We're going to talk about diagnoses and prescription drugs and clinical. It's going to be a lot of fun for the technical, nerdy people like us out there.
Excellent.
But before we do that, Stacy, why don't we go into your background? You have a really interesting story and how you got to where you are, and so I'd love for you to cover your bio a little bit for the folks that are listening.
Yeah, absolutely. So I originally grew up in the Boston area. I moved out to Philadelphia to go to med school 1,000 years ago now. And then I did my residency at Jefferson. And then for about 4 or 5 years, I practiced as an internal medicine physician in suburban Philadelphia. And just through a variety of circumstances, I was looking to do something else and transition out of clinical practice. And I happened to come across a company that was local to me that did denial management and length of stay programs for hospitals.
Okay.
And I ended up joining that company, which was great. I didn't really know anything about that side of the business, but we really helped providers get paid, reimbursed, mostly on managed care types of stays that had been denied. So we would overturn denied days to, say, acute days or subacute days, and they would get their $1,000 or $500. Nothing like what we see really in the commercial space in terms of what payers are looking at for bills. So I did that for a couple of years, and I gained this reputation for specializing in these super interesting, complicated cases. Really puzzles that needed to be put together, lots of in-depth research, really mystery cases in terms of trying to figure out what actually happened. And through that work, I ended up coming into contact with an MGU outside of Philadelphia who had an absolutely terrible case that they were looking for somebody clinical to review to tell them whether or not the person needed to be in the hospital for 432 days.
Yeah, when you told me that's the longest day that I've heard. 432 consecutive days, right, in the hospital. And you said the claim was somewhere around $1.7 million.
From what I remember.
Is smaller than I would think for a 432-day stay, but it was also a very complicated claim. So I don't know what detail you can and are willing to go into, but I think it was really interesting for this to be your first foray into this space. So tell us as much as you feel comfortable telling.
Yeah, absolutely. So, and this, I remember it, even 20 years later that it was 432 days because it was probably the longest day I still have seen in my entire career. And it really, it's kind of the way so many of these terrible cases start. Really just a woman who went in for a routine procedure, had an unfortunate medical accident happen to her when they were going to put her under for, I think it was something literally like having her gallbladder removed. It was very, very minor. She was an obese patient. They went to intubate her to put her under anesthesia, and unfortunately they intubated her esophagus instead of the trachea, which led to her vomiting while in a prone position.
Jeez.
So she had a terrible aspiration pneumonia, and really just a lot of things that kind of cascaded from then because, again, she was somebody who had kind of multiple medical problems just stemming from her obesity. But in the review of the case, there were just lots of little things that stood out as things you wouldn't necessarily see as standard of care. And it was, the more I got into the case, the more of these kinds of things that I saw, the more interesting pieces of long stretches where there wasn't a lot of care delivered and it wasn't clear why she really needed to be in the hospital. And that was really my job, was, almost like a forensic detective, to help the particular client figure out what portion of that stay really was appropriate to pay for. The claim had already been paid, so this was going to be, a dispute between them and their client. I believe it was already in litigation when I became involved. But through that experience and this MGU, I just became exposed to the world of stop loss, and I had in self-funding, and I had never ever heard anything like that. So
simultaneously, while you're going through this investigation, you were learning about self-funding and stop loss as well, which is an interesting way to be introduced to it, I imagine. But you were working with an MGU, so naturally you kind of had to understand the terminology and things like that, right?
Exactly. Yeah, I actually got to sit with all of their departments, and honestly, the laser meant nothing to me other than something that was in sci-fi movies. So I learned all of that technology, and they were great. Their medical management department, their claims, everybody, beginning to end. And I just became completely fascinated by that side of the business and the lack of these types of resources. Okay. And so ultimately what I decided to do was leave my previous employer. And I somehow convinced my brother to join me in this endeavor, and said, I really think that this is something that there's a need for. I think it would be great to start up this type of company with this type of service. My dad backed us for a year, and AMS was then founded in 2003. So we're 20 years.
Well, I got a lot of questions, especially one working with your brother for 20 years, what that's like. But I don't want to gloss over the fact that you went to medical school. You were a practicing physician.
Yes.
I think internal medicine, is that correct? For 5 years. So clearly you did that work. You probably enjoyed it to a degree while you did it, but it ultimately decided it wasn't for you. So what was it about being a physician that wasn't going to be your long-term career path?
Yeah, so there was definitely a few things. Internal medicine is, it's a hard specialty because it's not a specialty, right? It's really more of a generalist. So you have people who come in with lots of different problems, and you don't really have a lot of time for those problems. This is, back in the days where production and producing was everything. I had 15-minute slots for my patients, which just really isn't enough time to even scratch the surface for some of them. I think that it's demanding on your time when you're not in the office. Back before hospitalists, there was on call and having to go into the hospital. And I think it was really just the value that patients really did not have on the work that we did. And I will say that the final straw for me was I saw a patient. She was in for fatigue, which if you're in internal medicine is the absolute worst symptom that you ever want to hear, because that can be anything,
right?
Really anything.
Yeah.
And so, I spent a very long time, talking with her and figuring out a plan. And we came out and, I'm checking off my little sheet with her code for her diagnoses and her level of visit. And she goes to my billing clerk to pay her $15 copay. And she has, I'm not kidding you, Spencer, it was a little brown bag that was filled with nickels, dimes, and pennies, not a quarter among the bunch. And she tossed it out on the thing and said, I love coming to the doctor. It's a great way to get rid of my spare change.
Oh, jeez.
And I was like, I have worked far too hard. I trained all of those hours, far too much knowledge. I was like, there's got to be something else out there. And so I was looking for something that was just something that was non-traditional, that I felt would be challenging for me, but that would also excite and interest me the way I was excited about being a physician from the time I was 5.
And that's why I was asking you about this, because part of me thinks, well, maybe there's a level of not regret, but should I have gone to medical school? Should I have been a physician, right? But ultimately, I think you told me over coffee, the answer was, of course, it was well worth it, because it shaped what your skill set today. But tell me just kind of the psychology of spending all those years studying and training and ultimately deciding that wasn't your career path. What did that feel like? Or was it an easy decision at that point?
It actually was an easy decision for me because, again, I think I was just so frustrated with how medicine had become. And again, I'd always wanted to be a doctor. It was the only thing I ever wanted to be. And it wasn't what I thought it was going. It wasn't what I thought it was going to be. I wasn't able to do the things that I wanted to do and to be able to take care of patients the way that I wanted to.
Okay.
And so I was really looking for something else. And when you go to med school, nobody tells you about these non-traditional pathways. You sort of just learn it, on your own when you hit either the physician burnout or your practice gets absorbed or something. So when I found my next job doing this denial management of length of stay programs for hospitals, I was like, this is great. I'm still doing something as a provider and for a provider that uses my medical knowledge and uses my skills, but it also excites the more analytical side of my brain, that the mystery thriller kind of side, where I like to look for that one little piece that in that particular instance makes the day for them, allows them to get the reimbursement from the hospital, which at the time, and not kind of knowing anything about this other side of the business, was, monies that they desperately needed.
Yeah, absolutely. Yeah, I was thinking about that too, because I know how much time and effort it takes to get through med school, and obviously the hours are insane.
They are.
Did you choose internal medicine? Is that kind of just the path that eventually you found yourself on, though, just out of curiosity, that specialty?
I did choose it. I will say, I think I was a closet orthopedic surgeon, but having lived through the orthopedic surgery rotations with instruments literally thrown at me, I thought this probably is not
maybe
for
not.
me.
Okay, fair enough. Yeah, fair enough. And then, so before we move into AMS, I want to ask you too. I think you said you recently joined the board of SIA, right?
I did.
Okay, which is relevant because just for when we're recording this, the big SIA annual event is next week in October. So, kind of tell me about your experience and the desire to sit on that board.
Yeah, that's a great question. So I've been involved in some form or fashion with SIA probably from after the first couple of years that we had founded AMS. Once I became aware of such an entity, and I would go to all their conferences and do a lot of the educational sessions. I actually spoke at a couple of those. Obviously, the networking events are great. And then over the years, I've become involved in a lot of the committees. I sat on a drug price task force not too long ago. I've been involved with the Price Transparency Committee literally from the beginning.
Okay, great.
And just, some other things. I definitely need to give some props to Ryan Work. He and I have worked on so many projects together, and he has just been instrumental in bringing me into the legislative side, which again, I find inordinately fascinating and extremely frustrating as well. And so I have spent a lot of time at SIA. I was fortunate enough to get a call this time last year. Somebody had actually nominated me for the board. Mike Ferguson gave me a call to see whether or not I was interested. And I was, because I think that as great as SIA has been and continues to be, not that I think I'm the next generation, because there's definitely a generation, behind me, but I think having spent so much time at SIA, I just think there are definitely things that I am interested in doing to change it a little bit, to improve upon it a little bit, increase membership, open it up a little bit more, get people even more involved, because all of these things are really volunteer, positions.
Yeah.
And having an opportunity to sit on the board and be able to express these ideas and be able to put them into action was something that was extremely exciting for me.
I can imagine. I mean, SIA, ever since I've been in the self-funded space, has been a big part of what I do. I think I've attended almost every annual conference in the last 10 years, except during COVID. I've done the Future Leaders events. I think I was at literally the very first Future Leaders event a number of years ago, and I've always enjoyed the impact it has on our industry. But like you said, right, it's a constant evolution. There's a bunch of great conferences, great entities out there, and we're all trying to figure out how to stay in front of the changes in our industry, and then keep people engaged and educated and attract the next generation. All that's a part of what I do here, is to sort of talk to the next generation and let people know that this is a pretty cool space to be in.
Absolutely.
But I'll be curious to pick your brain of where you think SIA is going in terms of those evolutions. And of course, next week you will be there in person. But let's move into AMS, because I got you down here from Philadelphia, and thank you again for travel. And sorry about the hiccup with scheduling here.
Oh, no problem.
But so let's talk about the infancy of AMS. You said it was sort of a natural offshoot of some of these investigative claims claims experiences that you had. And so you stood this up with your brother. Brother apparently is more technical, right? Peter is he's the techie.
He is.
But it wasn't techie to start. So what did the early stages of AMS look like? What were you guys doing?
So the early stages, as I said, I had become involved with the MGU outside of Philly, and really saw an opportunity for these types of services, really marrying that clinical and financial perspective from a physician level.
Okay.
At the time, there were not a lot of physician-led organizations out there that fell into what, the legacy term now is the cost containment space. And so I felt that there was really kind of vast open space there to perform these types of services. And so my expertise at that time was in these medical reviews for these complicated cases. So AMS really started out with that piece. So we did lots of reviews for experimental investigational, medical necessity, length of stay reviews. And then as we were sort of working that and building up our, network of physicians, I was the medical director of an independent review organization at the time. So I had great access to lots of subspecialties to help do these reviews. And then as we're doing these reviews, I was like, well, this is great. The reviews come back. Everything is all clinically appropriate and medically necessary. But man, this bill is insane.
Yeah.
It's too high. It's crazy. I mean, it's just nuts what they're being charged for, say, a room or a drug and whatnot. And you didn't need to be a rocket scientist to figure that out. Like I could look at Tylenol on the bill and be like, okay, well, they're charging me $5 a pill for Tylenol. I can get 1,000 of those for $5 at my CVS.
Right.
So we wanted to work on the financial aspect of that. And so we started to add negotiations, provider direct negotiations that we did internally. And then we also added the provider bill audit piece. And then just as again, all part of the pieces of the clinical review came about, we started to work more towards the underwriting side of the business. So then we would help with cost projections for people. So companies who either didn't have any clinical expertise in-house, we became their de facto, folks to do that. Or if they did have clinical people in-house and they were looking for a second opinion. The broker didn't like that there was a laser, or somebody felt that there should be a laser, but it was too high, et cetera. So we became a second opinion shop for them. So that was really like where our
That's where it started.
grassroots
And so
are.
I'm curious, so this would be pre-platform, if you will, when
Yeah.
it wasn't a tech platform as much as it is today. Was this a per case basis? Was this a monthly contingency? How was somebody, not how much were you paid, but like how were you structuring the financial component of that for your services?
Yeah, it was either an hourly rate or a flat fee. I will tell you, and I was extremely adamant about that. I never really felt like anything that had to do with reviewing a case for clinical appropriateness should really be on a contingency fee. I just had a hard time with that. I know that things have definitely changed in the industry, and there are other folks out there who do that, and there's certainly nothing wrong with that. But at the time when I started, it was just something I felt very strongly about. So we never really went to that model for the clinical piece.
So no shared savings type arrangements or anything like that? Or
Not for the clinical reviews.
Okay.
For the financial pieces, for bill negotiations and bill audits, yes, absolutely.
Well, so that was early stages. So the evolution, right? I think you said there's 8 core sort of products underneath the umbrella today, but I know this is a 20-year-old company, so there's naturally going to be some of evolution during that time. So walk me through kind of the middle phases of what you guys built.
Sure. So, like I said, we were really, purely a clinical company. My brother had been, he's been many things in his life, but at the time he was the COO of a database company, an Oracle database company. And I didn't know anything about running a business when I started AMS. So I really valued, and still to this day value, his expertise in running a business. And, he taught me how to do that. But his love really has always been in the technology part. Mm-hmm. And so we're kind of percolating along, doing well in that whole cost containment space. It's starting to get more crowded as the years go on. And so we get up to, say, around 2012 or so, and we had happened to have a client company approach us about developing a resource for them that would help them in cost projections. And they kind of had a laundry list of diagnoses, and they wanted to know if we could build something out for them that would help show them basically what treatments they could expect in an upcoming year and how much that would cost.
Okay.
And so I took a look at it, and kind of what they had. I mean, it was great. Don't get me wrong, but it was a little rudimentary in the fact that it didn't break things out enough. They wanted, cancer was one of their categories, which would
just
be
cancer broadly.
No,
Okay.
What type?
Yeah.
What stage? There's a whole bunch of things that go into that. They would have like metabolic disorders. We wanted to be a little bit more specific, and so. I went back to them and we're like, this is where we think you should go. It should be a little bit more robust, et cetera. This would be the price. And they passed on doing that.
Really? Okay.
They did. Which I do think that they regret at this point because they've been clients of ours for a long period of time. So my brother said, because I put this all together on my extremely techie Excel sheet. That was the extent of my technological knowledge at that point in my career. And he came to me and he said, Stacy, look, I really think we have something here. I think that this could be a product. I think we could do something with this. I think we could do development. I know how to do the development of this. And he literally said to me, what I think we should do is just crack your brain open and put it into some software. And I replied with the absolutely not statement. It's too much work. I was like, you don't understand is what would have to go into this, the number of diagnoses and how we would need to do it. And he said, okay, that's fine. Because he's been my brother for a very long period of time. And he knows that, if I say no at first, he needs to just wait it out a little bit. Let me think. And then, I came back to him it probably took me a few months, of thinking and pondering of, no, I think we could do this, and I think we could do that. And I went back to him and I said, all right, I think we could actually do this.
Okay.
And so that is where PredictDX came from. We started out, I think it was 140 diagnoses when we first started out. Now we're at like 250. But we were very specific because we were in the stop loss space. And those were our clients. So we were very, very rigid in terms of the diagnoses were going to be catastrophic diagnoses. Okay. They weren't going to be things that were easy peasy, in and out of the hospital, that people in our industry weren't going to care about. So we really made a concerted effort to narrow those things down to the things that would be considered catastrophic, that you would worry about kind of across the spectrum.
Now, would that be conditionally based or would that be a certain dollar threshold? How do you define catastrophic?
Yeah, so that's a good question. I mean, if I really think back to those days, I think in my head it was more clinically based because these would be cases that would be often chronic and ongoing. Okay. So a lot of your cancers in that. But then the more I thought about it, there were more things that may be acute that you would go into the hospital for, but could cost you a whole bunch of money because the treatments may be very expensive for that. And so again, I really think, the primary tenet for us has always been that marriage of the clinical and the financial piece. So
that was PredictDX. So DX being a shorthand for diagnoses.
Yes.
And I think you said the second one that was stood up as a result of that was PredictRx. Is that correct?
Yes.
Okay. So DX was excluding RX at the time then, or just sort of rolling it up under and you decided it needed to be its own category?
Yeah, it was more that, so we would outline the treatments for a given diagnosis.
Okay.
And we would attribute cost to those. So we would talk about, just like, again, sticking with the cancers, chemotherapy for the cancers and whatnot. And then so we would give a cost for chemotherapy, but we weren't really breaking the drugs out. And there's a wide variety of costs that go along with that. Older ones that aren't nearly as targeted versus very, very new ones that are your much more targeted therapy, very expensive. And so what we found was, especially things that had solely drug-focused treatments, something like Crohn's disease or ulcerative colitis. Certainly they have their surgeries that go along with them, but they are very medication managed. So instead of putting what we would have initially would be drug therapies, and we would give a range of costs for that. And then we found people who were very interested in, well, what are those drug therapies? And how can we break those out? And there's 12, 15, 20 for some of these diagnoses. And so we thought that would get too overwhelming to actually put into DX as it was, because it already had a lot of information in there. So we thought, why don't we take that, make it its own directory, RX being short medical shorthand for prescription, those drugs. And that's where we would put all of the information about the drug, because there would be drugs that you would want to put in there that have multiple indications. Some of those indications may be for diseases we don't necessarily focus on in DX, but they might be of interest to people for whatever reason, especially places or groups that would have very low specs. $25,000, I mean, you could breach that with a pregnancy at this point, you know, and a lot of these drugs were starting to hit these lower dollars. You know, stop loss carriers didn't necessarily care about them, but certainly first dollar payers, you know, TPAs and brokers and case management firms and all of these other folks that are in the industry. So we thought, well, let's make that more comprehensive. So we will list all of the different things that the drugs treat and what they're indicated for and what their costs are, even if all of those things are not in our DX directory.
Okay.
And so that's where we came from.
Is there a marriage of both of those? Let's say a big claim includes medical and RX diagnosis, so then you would just pull it out into how does that come together, right? The systems talking to each other, or they're inside the same system, just different locations?
Yeah. So it's web-based, and like I said, it's a platform. So you can go in and you subscribe to one, both, all of our products. And so if you have both DX and RX, you can certainly, you know, look those both up. They're within the same platform, one login. You just go to the different directories. But we also have shopping cart features. So if you're trying to, say, build out a cost projection for a given treatment, you can pull a surgery from DX, you can pull a drug from RX, you can pull whatever you want, you know, from either of those directories, bundle them all up, put them in a shopping cart, and give you a number that will make sense for, say, the next, I say 12 months, but some of these things, you know, they're acute, they may only be 6 months, but for wherever an episode of care would be.
Yeah, and the goal is obviously to identify what's reasonable, what's customary, what is appropriate for the length of care, but ultimately for these very large catastrophic claims that have very, very high ticket amounts associated with them, getting them through clinical underwriting for firming up stop loss is an example. Perhaps, like you said, lasers, conditions of lasers, whether mitigating that laser, avoiding that laser, things like that. What are some other use cases that you find these, especially the risk-bearing entities, are using your platform for?
Sure. I mean, there's really a whole spectrum, and a lot of it depends on who you are and what seat you're sitting in to look at that. So yes, underwriting is certainly a big part of it. Setting reserves, you know, for the rest of the year certainly is a way people look at it. Whether the treatment is actually appropriate, right? We have people who do look at it from a clinical perspective. Is this something that is appropriate for a given person? People who are looking for price trends. We have lots of different benchmarks that are in there. Where are prices going for given surgery, say, or for a given drug? I think, again, like there's just so many different ways that people can use it and slice and dice the data. How risky is somebody? You know, what can I expect if let's just say they have a history of this? Well, is that 5 years ago or is that last year? You know, what's the risk of recurrence? What do these costs look like going through certain networks in certain states? How does that impact where I may either set a reserve or think about how much somebody is going to cost me? But these two directories, you know, are very static.
Okay.
You know, they're research directories. And so we really wanted to help people more with an active product where they could actually give us more data, and then we could help them lift and sift through the groups to let them focus on the people who might be really their problematic people.
Is Profiler,
this
correct?
Is Profiler.
Okay, which I love the name, right? It sounds like, hey, it sounds like a little bit of an investigation and digging into some details on profiling things. But
because it goes along with my little mystery.
It does, yeah. So what does a profiler do? What is that particular solution?
Yep. So, like I said, Profiler is really it's a much more active product, and it's based. All of its content, though, is really based from Predict DX and Predict RX. But this allows our clients to feed into it all of the data that they receive when they're assessing a group.
Okay. In
whatever format that might be. You know, lots of it Excel spreadsheets, et cetera. Millions of lines of data to try and sort through and figure out. So they can plug that all into Profiler. Profiler does its absolute magic, cleaning the data, sorting the data, sifting the data, and they put in, you know, whatever information they want. So whatever their spec is, if there's an ag, effective dates, et cetera. It lets them look at the history of all of these claimants, and then it really ranks people as according to most risky to least risky. All anonymous,
de-identified
data to us. Now it tracks to whatever they're able to identify, through their system, and then we tell them by looking at what treatments the patient's getting, what drugs that they're on, really what do they need to worry about in the next 12 months. But then it also gives them a ton more information. Like, you're paying this amount for this drug. Well, here's a whole bunch of benchmarks ranging from, your Medicare pricing to wholesale acquisition costs, average wholesale price, all of these types of things versus, what you're paying. So opportunities to really look at networks, to look at the various providers. Where are your problem providers? What are your problem groups? Where are they running through? Perhaps you have either a contract problem or a network problem. So it gives them a lot more of that business
when
intelligence.
It identifies those red flags, if you will.
Yes.
Then does it offer up or make recommendations, or is it up ultimately to the person interpreting those problems as to where to go next? Like, how involved do you get in this to kind of steering the solution?
Yeah. It's really up to them to kind of decide what to do next. We have cute little icons that let them know, like, hey, this is a high risk maternity. Maybe go back and get some information about this person. How's the pregnancy progressing? Because the baby's going to be delivered, say, in your next policy period. Is there potential for gene therapy? Is there potential for CAR T therapy with this diagnosis? And so it really gives them, we stay neutral in it, but it gives them the opportunity to then go back and ask all of those questions to figure out what they want to do with a specific case or a specific network or a specific contract. But we're there for that support aspect. So we offer all of our clients that support. So if you're interested in, hey, what do you guys think about this case? We are happy to take a look at the exact same information you've submitted and say, yeah, this is what we think, or here's some additional questions that you might want to
and I think that one of the broader sort of directives, it seems like, around that is transparency. And you and I are talking about coffee. Transparency can mean anything and nothing simultaneously, depending on what a person means. But with a goal of providing transparency through Profiler, and I think we'll move into Census Rater next. Like, what does that mean to you to be able to provide transparency, and transparency into what is the ultimate goal?
Sure. Yeah. Well, I think it's the ability, again, marriage of the clinical and financial.
Yeah.
I think I'm going to just keep coming back to that.
Well, we might have called this episode "Marriage of the Clinical and Financial." Yeah,
that's true. Well, we'll need an officiant for that.
Yeah.
It is really that transparency into how should things go, right? So we can tell you everything you want to know about the drug and whether or not this is standard of care for your given patient. To me, that's very much clinical transparency. It is up to the client to decide what to do with that, because I, as a completely external person, an external company, have absolutely no visibility into what else is going on, right? There's a lot of things, how important the group is to them, all of the politics that are playing into that. And so I may feel that this isn't appropriate, but there may be other factors for why somebody decides to cover that.
Okay.
I think the financial transparency that it can bring, especially now as we add a lot of those chargemaster pieces in, because we've spent all that time to do that, and bring in all of those pricing benchmarks from all of the hospitals that will publish it. It's really the opportunity to now have as much true financial transparency as you can.
Well, you said you pull in from 5,500 hospitals or something to that effect, out of 7,000 plus. But you also told me that some of them just decided not necessarily to publish, or at least wait and see, and maybe even deal with fines.
Yeah,
that seems like a really rich pool and to draw insights from. And so, what is the data telling you so far, out of curiosity?
Yeah, so it's great, data in and of itself it's always just dirty. It comes in, it's a mess, and no two hospitals publish the things the way that they're supposed to. So that in and of itself, I think, is already a piece of transparency that we're providing, because we've synthesized all that data, we've standardized all that data. See, I'm getting excited.
Yeah, I know you are, and I like it.
We've standardized all of that data and made it into a format that people can read. Machine readable format does not mean at all intelligible whatsoever.
Yeah.
So we really did the work to do that. So to me, that's already the first piece where you can see what is going on. The things that we found are, yes, there are definitely providers who are not, publishing this, and they're not allowing you to really have any transparency into that. We've also found that sometimes what providers are publishing as a billed charge is not actually what is being charged on a claim.
Really?
And Profiler will let you see that.
How so? How's it not the same thing?
So let's just say, again, I'll come back to my Tylenol example, that their published chargemaster price is a ridiculous $5 a pill. Well, then you get a claim in, and we can tell on that claim that the pill was actually charged at $7.50 versus $5. So it's not even a ridiculous price that they've published. It's an even more ridiculous price.
Okay.
And so, and when you start talking about, how we evaluate and reimburse on claims, and you talk about discounts and PPO arrangements and whatnot, you're often starting from these completely falsely elevated numbers. And so, chargemaster, allows you to really see where you're starting to have those problems. Profiler will also let you know who are your most problematic providers, who is charging you the $750 all the time for that. So it gives you a little bit more, and I think that everybody knows to some extent which one of their providers are a problem. But you're very often surprised because there are providers who can be a problem, but they operate at a much lower number under the radar in terms of the dollars that are involved for you.
Okay.
So you're focused on the low-hanging fruit.
Yes.
But it turns out you may have a much bigger provider problem for a certain drug. Maybe there's an opportunity to move that to different site of service, right? Somewhere where I hate to use the term brown bagging because I know it's the utopia and it's very idealistic, but there are some opportunities maybe to do that where you could get the drug at a lower price and the patient could actually bring that. So chargemaster, I think, is the product that gets you as close to true transparency.
Well, and that's all. I don't think there's a panacea where we get the exact right dollar amount for everybody in every condition and every location. That's never going to be possible. I think that's a goal that we shouldn't even pretend that we're trying to pursue. But it's getting us, like you said, as close to possible. What is the relevant charge for this thing in this location in this situation? And then having a sort of coherent baseline amongst those entities who are ultimately competing for demand or competing for supply of patients and doing so in a way that is a little bit more open and a little more visible. And if I am the individual patient or my employer as well, will know what this probably is going to cost. And when you look at it on a paper and you review it, you go, everything here looks appropriate, right? Not to say there's no margin built in. Of course, these entities need to make money.
Absolutely.
So, but my brain presumes cash is always that closest metric, but you were telling me over coffee, not always the case. Maybe 80% of the time it is, 20% of the time it isn't. So when is a situation where cash actually isn't necessarily the lowest barometer there?
Yeah, that's a good question. Again, I think it is going to be very specific. Sometimes it's going to be provider specific. Sometimes it will be not just only provider specific, but a particular code specific. Okay. So it's not necessarily that the cash price for, say, a given hospital will always be or won't always be the best price, but there could be specific codes that may just unfortunately be on your claim where it isn't. I also think, as we talk about cash price and what providers will accept because they do, otherwise why would they have it published? It's so frustrating to see how different that can be than what payers are doing under these contracts. Yeah. I think some Medicare pricing, Medicaid pricing will certainly be less than your cash price. But most of the time, we are reimbursing far more than what they would take from a patient who just walked in off the street and didn't have any coverage whatsoever. And I think that should be something that everybody really should be aware of, because as we do try to move the needle in terms of working on these costs, cash pricing, I think, could be a really good jumping off point.
I do too. And reference-based pricing is sort of inched us closer to what that benchmark should be. Cash is on top of that. I think if we just continue to shine the light and try to source this data, you guys are doing a great job of, like you said, synthesizing it and making it readable and legible for the normal person. We're going to get closer towards what that number should be on most situations. And I think, again, it continues to sort of undermine the network, if you will, and discounts off billed charges and that the funny money that's all part of this equation where it just frustrates everybody involved, including the providers, and obviously the patient and the employers as well. And that's the ultimate goal. It's just, can we just get a number and a transaction that acts like every other financial transaction in the U.S.? That's all we ask for. Right. But I want to leave some time. I know we've got about 15, 20 minutes left. I want to leave some time.
Really? This has been fun.
I know. And that's, again, my scheduling snafu. Fast. We'll stay until they kick us out. I don't see anybody waiting for us. But I do want to talk about Census Rater because I think that's one of your newer products. It's a little bit down market for the smaller groups. So tell me about that solution, and then we'll zoom out to big picture healthcare in a minute.
Yeah, absolutely. As you mentioned, so Census Rater is a newer product for us. We actually did launch it back in 2021. Didn't really see a ton of adoption. I don't know if people were not really thinking about small groups as much, or there are certainly other resources that other folks were using, but we were really trying to give people much more information from that. So kind of took a step back with that, went through an entire rigorous process of actually having evaluated by an actuarial firm to verify accuracy and validity of it. And then we've just actually relaunched it.
Okay.
Very recently. So the difference between Profiler and Census Rater is Profiler is what you use when you've got information. It's either a group you've had, a group you're renewing, or they're coming from something else that is already self-insured and the incumbent carrier is willing to share information with you. Census Rater is really designed for when you have absolutely no information other than the census. And so we feed that into our database, and it does similar things as Profiler, where it lifts and sifts and lets you know potential problems. The big difference is, well, there are a few differences, but the big difference is it's not down to the member level.
Okay.
You can't get down to the member level. What we use is, we don't use any third-party data for Census Rater. From all of the years that we've been doing this, we have about 212 million claimants representing trillions of dollars that have been paid throughout the entire industry. And so what we do is we benchmark whatever group is being fed into that data.
Okay.
So it's big anonymous data.
And it's looking for like the region, the size of the group.
Right.
Is it taking in demographics, obviously, from the census and blends?
Age. I mean, that's pretty much all I get with the census is, age,
and sex.
Demographic, location, sex, if you're lucky.
Yeah.
And that's pretty much it. So what we're doing is we are looking at similar patterns, right? So we're looking at groups that look and smell like this group in this area, and the statistical likelihood of those members in your group having a wide variety of diseases.
Yeah.
And so again, it's all internal to us, so we're not going out and scraping other databases and pulling that information. We don't use social determinants. And I know you and I had that particular conversation. I do know that there's been some things published about, how valuable are social determinants, and it doesn't look like they're as valuable as perhaps we may have thought. I personally am not the biggest fan of them. I don't think they can be as helpful as some other things, but I think knowing what similar groups who have similar age members in a similar demographic region tend to get is probably as close as you're going to be.
Well, I would say we're taking a preponderance of like circumstantial data, right? And trying to piece it together into a picture of a particular group. And I imagine something like Census Rater is going to be directionally accurate, but it's hard to maybe be accurate on an individual case, right? If you will, because it is taking sort of a broad base of metrics and putting them together. And so like, how do you sort of position that as a solution for that 20 life group that's looking to get some data and self-insure, right? Like, how do we build it up so it's robust enough to have a risk-bearing entity make a good assessment of whether or not to take that case? Yeah.
Well, I think the large volume of data that we have really does, and again, we really went through this whole actuarial process to see how accurate it is, and it is inordinately accurate. But I'm not going to sit here and tell you that Census Rater is the end all and be all to everybody's problems, because I don't think that there's really any one solution.
Exactly. Yeah, I'd agree with you.
To this. Yeah. I think that you need to take whatever you can get.
Yeah.
So you take Census Rater and you look at that and you say, okay, statistically, I have a likelihood, against this deductible of this member doing this, and I'm going to think about that and adjusting my risk. But maybe I am going to look at some social determinants in this particular group, or if I know something about this particular area, I'm going to add that piece in, or I'm going to pull something else in. I'm going to look at something external that I'm getting on my own. And I'm going to put that puzzle together and decide, for myself. I think that really anybody who's going to say that like their product is the one and only thing, that's the only thing that you will ever need, is really sort of doing a disservice.
I would agree with you 100%. And the ultimate goal that I would be getting at is like, how do we pull all these together to get the most accurate picture we can of a group that doesn't have data? So the more that we transition to be self-insured, where you are now getting data, you are getting a better picture of what's under the hood. And so making a cleaner risk assessment to pull more into the pool of ones that will obviously be profitable cases, because we want these carriers to make money so we can sustain the pool and all that stuff. But then not to have these huge misses as well, where they end up taking on some really, really bad risk that's bad for that entity. It's bad for the employer too. Ultimately, if they have to go back to being fully insured, or they find themselves in a market where they can't get stop loss now that we've looked under the hood, that's obviously a worst case scenario. But directionally, there's a lot of entities, and I love that you guys are going down this path as well to solve this problem, because the opportunity in that size segment is immense as well. So,
I think so.
Said it's a second go around, but kind of a relaunch. I mean, how do you view that product sort of evolving over the next couple of years to get just fine tuned even a little bit more?
Yeah, I mean, I think that given the wide variety of client base that we have and the more data that we're able to ingest, and I don't want to say re-engineer, because we're not doing anything, we're not changing the data, but just being able to present it in a format that they're able to make some decisions from is, I think, where you need to go. You have, and everybody has, so much data that is out there. And it's a matter of figuring out what's good, what's not good, and making sure that your data that you're using to insert into these conversations is as accurate as it can be, and really trying to eliminate as much dirty data. So for us, and I think I told you this before, we're very much about staying, in our lane and doing these types of things where we focus on these kind of catastrophic things. So we're really dedicated to, looking at these types of pieces and bringing in as much data as we can and just refining it, further and further. Again, with a census, I think there's just only so much that you're going to be able to do, and you're gonna have a surprise. You just start. Somebody's going to have a premature baby that nobody's going to ever see coming, regardless of if you're coming from fully insured or you're not coming 100%. From fully insured. So I think it's just, incremental.
What role, and I think this would be a good way to kind of segue into the big picture stuff, what role does artificial intelligence play in all of this? And I think you even said there's a upcoming forum with SIA on artificial intelligence soon. So I think it's a relevant, hot button topic for us to discuss. So what role does AI play for you? And then maybe just industry-wide, what role AI will play in your vision?
Yeah, I think it's a big thing. I think it's a big scary thing for people in terms of, what AI actually is and what it can do. And I think people get nervous about a wide variety of things with that, especially in terms of PHI and HIPAA and having their, information, sort of exposed as things get scraped off the web, and these large language models or, and ChatGPT I know is everywhere, et cetera. So I personally, I have to say, I probably am the one and only person. I've never actually used ChatGPT at all. Okay. But I think that AI is a really good way that you're going to get even more robust analytics. You're going to be able to take a lot of this data and really kind of synthesize it in a way that we aren't currently able to do today. We're going to be able to look, I think, much further down the road than these 12 months. We're going to be able to do a lot more with historical trends and what does that really mean in terms of the go forward. I think its role, separate and distinct from the self-funded world, just on imaging alone and how we look at medical studies and diagnoses, I think that's going to really revolutionize that particular industry. Yeah. Absolutely. But I do think that in the world of data analytics, if you're not thinking about, how to start to incorporate more of that machine learning, feeding more data into the machine to get it more proficient in terms of turning out things that make sense and that are accurate is really where we're focused, trying to really refine and improve on all of the things that we're actually doing.
Yeah, I love that. Yeah, I mean, at the end of the day, it's about patterns, right? Recognizing patterns. I do like the accuracy in the diagnosis world as well. I mean, we've talked about this over coffee, and I've had this conversation a lot recently. I don't believe AI is replacing physicians. My hope is it's augmenting their ability. Because if I'm a doctor and you come into my office and I have 7 minutes with you as a patient, right, or whatever the average time is, there's only so many things that I can glean. Am I paying attention as much? Are there distractions? Are you distracted? Did I have my coffee yet, or my second cup of coffee? There's all sorts of inherent biological things that would impact my ability to pay attention and get the most accurate diagnosis. I think AI has fewer of those biases because it's sort of objective and it doesn't have things that would intervene or prevent me from paying attention as well. With that, though, also requires the person to be accurate and be the person feeding it data or questions actually be truthful.
Yes, for sure.
Which, we as human beings have biases the other way, where we don't want to disclose that I smoke cigarettes, or we don't want to disclose I had 3 drinks this weekend or whatever. And so it still is dependent upon some of the information that's being fed. But I do think we can fine tune, directionally speaking, to make our doctors a lot more accurate when it comes to actually triaging those diagnoses and then making recommendations. I do think that application, especially in the pediatric world or the primary care physician world, is an absolute obvious pathway. Anything else that you're seeing in terms of an application for AI immediately, or that will be talked about next year at that forum?
Yeah, well, I think there's going to be a lot that we're going to really be talking about in that forum. I think a really hot topic, especially in the world of self-funding, is how do you start to incorporate AI to help you win business within that, right? In keeping those cases. What can you look at in terms of your own data that will help you either select a group that's going to be more profitable, or just something that will allow you to look at groups in a different manner than you perhaps were looking at them. So that, I think, is going to be a big focus. I think the caveat, though, and this will also likely be one of the sessions. So Mike Ferguson, don't kill me for revealing anything. Is all of the legal and regulatory pieces that are going to have to go along with that, right? Absolutely. Because that is just going to be much slower to keep. AI is developing at such a fast pace. I think there's a lot of things that we need to talk about in terms of what are the potential issues in using this data, especially as litigation
starts. Ethics and things like that, right?
Yeah. Because litigation is already starting to make it through the courts. I think we also need to have that conversation about AI and how that affects people. Right? Because people are so worried about AI replacing them and doing their jobs. I think doctors, and I can say this because I am one, we're probably arrogant enough to think, hey, nobody's going to actually replace me. They're still going to need me. But I do think a lot of people who work in our industry, especially in jobs that require a lot of data analytics that they're doing manually to date, view AI as a threat. And I think we need to come to terms with that, of how we can all play well together, using AI not as a tool to get rid of people, but as a tool to help people be more efficient and better at their jobs.
Well, and the argument always is, like, we have the advent of the internet, which we've seen in our lifetimes. The argument always isn't that jobs are going to be completely eliminated. I think a lot of what happens is some jobs are eliminated, but a lot more jobs spring up as a result of that. So you're seeing like prompt engineers with ChatGPT. So these people that are specialists in knowing what to feed into it to get the results that they're trying to glean. So that's a brand new job as a result. And again, my hope is I think these technologies in and of themselves are inherently, not ethical or ethical. They're ambivalent. They're neutral. The point would be, how do we use these tools, and how do we use them to encourage human proliferation and prosperity, and sort of diminish the suffering as a result of that. And
I agree.
The answer to that is obviously very vague, and it's hard to parse exactly. But let's kind of zoom out. I know we got like 2 minutes left. I don't see anybody again knocking at the door, so we'll go to the very last minute. But Stacy, why don't you just tell me kind of your future vision of healthcare in general, your closing thoughts, if you will, for the podcast.
Yeah, I mean, that's just a very narrow topic. So easy to do.
And sum it up in 30 seconds.
So, I think I think my main focus in terms of healthcare are the development of these new therapies, of the new cell and gene therapies, and where are those going, right? We're starting. I mentioned this earlier too when we were chatting. We're in the flat end of the hockey stick, but we are very ready and rapidly going to approach the steep end of that curve. There are going to be more cell and gene therapies that are going to come out. Adoption is only going to increase. These developments are going to be for people that have a higher patient population. It's not going to be only for the rare diseases. In fact, the vast majority of research in cell and gene therapy right now, cancer.
Really?
All cancers.
Yeah.
And yes, there are definitely more rare cancers than not, but they're not, even the rarest of the rare is still more common than some of these genetic diseases that the gene therapies have already been developed.
Well, how do we prepare? How are we seeing employers prepare for this, or payers as well? Like, how are we preparing for? I don't want to say an onslaught, but we built into the equation will be the presumption that there's a certain level of utilization and there's some very high price tags. So how is everybody kind of preparing in what you're seeing?
Yeah, well, I think it's really across the spectrum. I've had multiple conversations with folks who are looking at we're going to take a pause. We're going to exclude coverage on these. They're rare enough right now. We're going to exclude the coverage until we can kind of figure out what we're going to do. But I think it's a problem that is truly vexing the industry, and I think it's something that we're going to have to deal with right now.
Yeah.
And really can't wait because there's only going to be more genetic therapies. So how does that look? I think we need to be talking much more to the manufacturers and getting them involved and really pushing for more outcomes-based contracts, right? So that if this therapy doesn't actually work, it's not durable, it doesn't do what you say it's going to do, you're going to get some money back. And how are we going to do that? Those conversations really need to start happening. And I think we are going to have to look at, what do the risk pools look like? Is there an opportunity? Is there an opening to do that? Who's going to manage that? I think the cell and gene therapy space is actually going to spring up a cottage industry of its own, totally related to coverage.
Yeah, I absolutely agree. And I'm very curious to see how that's playing out, not just from the lens that I view it from Pareto, of course, we're thinking about this, but everybody's talking about gene therapies. And, I think the exclusions make sense maybe in the short term, like you said, to hit pause, but it's not a solution, right? It's just deferring something that's ultimately going to come back around at some point. And so I think industry-wide, we need to have a very serious conversation about how we are going to absorb this into the entire risk pool and manage it appropriately, because there are some very, very profound positives from a medical perspective that are coming out as a result, but the price tags are unavoidable. So we have to have that conversation. So I do see somebody's looking to get in now. So we'll go ahead and wrap up here, Stacy, but maybe just closing thoughts as we exit the podcast, what you want to leave the audience with.
Well, I think that it's great that you're doing this podcast. I think it exposes people to ideas and opinions and thoughts of things that they may not have actually considered. And I think that the industry as a whole really needs to think about how much more proactive that we can actually be. We need to be less of a react to things that are happening in circumstances and really try to get out in front, because I think that's the best way for us to really get ahead in terms of a lot of these issues that face the industry.
I couldn't agree more. And again, I'm sorry to create a sense of urgency at the end. It kind of made it exciting and fun. But we did talk for right at an hour, which is kind of hard to believe. It goes by very fast. And I suspect that you and I could have spent another hour talking. Absolutely. So maybe we'll have to do it again down the road. But again, thank you for traveling here. Sure. Again, sorry about the little scheduling snafu, and then looking forward to maybe seeing you in Arizona next week as well.
Thank you so much.
My pleasure.